As a reminder, the information provided during this event is for educational purposes only. If you have any questions regarding medical conditions or treatment plans, please consult your physician. Now, let's get started. Joining me today during GERD Awareness Week is Nikolai A. Bildzakevich, MD, FACS, Director of Foregut Surgery at Providence St. Jude Medical Center. Welcome, Dr. B.
Oh, thank you, Brendan. It's glad to be here.
Could you start off by telling us a little bit about yourself and your role here at Providence?
Yeah, so I'm originally from Pennsylvania, just grew up north of Philadelphia. Did my undergraduate work, attending a Bachelor of Science in Biology at Ursinus College, which was a small private liberal arts college. I then obtained a medical degree from Jefferson Medical College in Philadelphia. While there, I joined the United States Navy on a scholarship program. So following graduation from medical school, I did an internship in general surgery at the Naval Medical Center in San Diego. Following that, I became a naval flight surgeon. So I spent 4 years on active duty with the U.S. Navy, taking care of pilots and air crew. Returned to Jefferson in 2005 to complete my residency training in general surgery. Did a fellowship in minimally invasive surgery at the University of California, San Diego, where I had a big focus on foregut surgery at that point. And then prior to coming to St. Jude full time, I was an associate professor of surgery at the University of Southern California in Los Angeles, where a lot of my practice focused on foreguts. I've been at St. Jude Medical Center for about 3 years now, but full time starting in May when I was appointed director of foregut surgery.
Wow. So I have to ask, did you see the new Top Gun movie?
Yes, I did. It is quite excellent. So I've seen it multiple times, actually.
Oh, excellent. Glad to hear it.
But I will tell you, Top Gun, when I was a flight surgeon, that was people who wanted to be Maverick. They were usually not the best candidates to become naval aviators. So,
Wow. Okay. So can you explain to us a little bit what exactly GERD is?
Yeah, so it stands for a gastroesophageal reflux disease, and reflux in of itself is a normal physiologic process, and we all experience that from time to time, especially around this time of year during the holidays when we tend to overeat. But it really becomes a disease when that reflux causes troublesome symptoms and or complications that we can discuss a little bit later. But it really is a mechanical process. I would probably think that half the patients who come to see me think they have more acid than their neighbor, and that's why they're here. But it's not a disease of too much acid or too strong of an acid in the stomach. It's really that mechanical process of acid refluxing up into the esophagus through what we is a weak lower esophageal sphincter. So meaning at the end of the esophagus, where it meets the stomach, there's a circular muscle or mechanism called the lower esophageal sphincter. We simply call it the valve. And in reflux disease, it usually opens properly during swallowing, but doesn't close properly. So it allows the reflux of acid, digestive enzymes, and food particles back into the distal esophagus. So The one thing I definitely want everyone to take away from today is that it's not a problem of too much acid. The problem is that valve.
Wow, that's really interesting. So what are some of the common symptoms that are typically associated with GERD?
Yeah, so we break down symptoms into typical as well as atypical symptoms. So the typical symptoms are what we call heartburn, or a burning sensation, kind of that presents in the upper abdomen or below the breastbone or substernal area that usually is associated with eating, as well as regurgitation, where that stuff kind of comes up into the back of patient's mouth, usually with a sour kind of bitter taste. But I will tell you about 20% of patients with actual reflux disease never experience heartburn. So there are some other symptoms. So trouble swallowing, what we call dysphagia, potentially, or odynophagia, which is actually painful swallowing, is usually more of an alarming symptom when patients develop those symptoms. But we can also have some more like atypical symptoms. So that acid reflux can make it all the way up into the back of patients' mouths. So it can affect their sinuses, so recurrent or chronic sinusitis. That acid can eat away at patients' enamel and their teeth. So it can cause dental problems and gingivitis, as well as that acid can make its way down into the lungs and passing the vocal cords on the way down. And so often patients may complain of hoarseness or other voice changes, They may have a chronic cough, which obviously can be due for many things, but also can be due to reflux. And then there's something called a globus sensation, which is people just describe as if they feel like they have a lump in their throat or a ball that's just stuck there. That's clearly associated with reflux disease. So.
Well, I know I've felt that sensation when I've taken a vitamin that's pretty large and I haven't taken some water with it, but this sounds a lot more serious. Now, as you mentioned earlier, we are about to trudge headlong into the high holidays of the year, and I know I keep a bottle of Tums safely down in the restroom for when I need it. But lots of people, I think, experience either heartburn or acid reflux on an occasional basis. But how should I know when I should be concerned and try and make an appointment with a doctor such as yourself?
Yeah, so generally, patients that are well controlled with, if you look at diet and lifestyle modifications. So again, we ask patients to avoid certain foodstuffs, which are difficult in our half of the world. So we ask them to avoid fatty or fried foods, carbonated beverages, alcohol, mint, citrus fruits, cranberry, especially this time of year, right? So there's basically food stuff, or when those products are metabolized, there's breakdown products that cause that valve to further relax, hence aggravating reflux. Diet and lifestyle modification, the studies have shown that it can be successful, but only in a small percentage, about 5 to 10% of patients. So medical therapy, as you mentioned, the antacids, the Tums, right? Those are good for the good social relief. But there's additional medical therapy such as H2 blockers, such as Pepcid, or most of the time patients will be put on a proton pump inhibitor. So unfortunately, because a lot of these medications are available over the counter, patients aren't even seeing their primary care physician or their GI physician for care. They're just picking up these prescriptions at Costco, right, or at the neighborhood, the grocery store, kind of self-diagnosing and self-treating. So, but to answer your question, patients who generally aren't well controlled on medical therapy or have any alarm symptoms or any concerning findings of such as complications of reflux disease on endoscopy should be referred for further evaluation.
Okay. So talking about further evaluation, what kind of tests are usually done to confirm or rule out GERD in a patient?
Again, so the current guidelines, if a patient presents with typical symptoms of heartburn, regurgitation, and they're going to undergo a brief course of medical therapy, and this can either be done with H2 blockers initially, and then if the symptoms still persist, step it up to what we call proton pump inhibitors. Other physicians will kind of start out with the proton pump inhibitors and do a step down, or and kind of wean them off, maybe down to the H2 blockers, which are not as powerful but have more preferential side effects. And so, if you're treated adequately with that, then a lot of those patients, which is a small subset, won't need further evaluation. But again, those patients who have complications of reflux disease or are unresponsive to a trial of medical therapy or relapse after discontinuation of medical therapy should be referred for further evaluation. And that usually warrants anywhere from 3 to 5 tests. So upper endoscopy is the most important study to look for complications of reflux disease. So that obviously involves sedation, and we put a camera to go down. And again, that allows us to evaluate for complications before they become symptomatic. In the absence of any significant complications, a pH study is also warranted to evaluate for reflux disease. This is the gold standard in diagnosing reflux. There are a couple different ways to do it, but the best way is what's called pH Bravo, which is a wireless motility capsule. It's done at the time of the endoscopy. So at the end of the endoscopy, we implant a small capsule. It's a little bit bigger than a pencil eraser, right above that weakened valve. And patients will get a little receiver that they can carry in their purse or kind of put it in their pocket or clip onto their waist. And anytime acid splashes on that, it sends a wireless signal to that receiver. And then they do that for a couple of days. And then after a couple of days, they bring that receiver back. We plug it into the computer. We generate a lot of data, but it really gives us a complex picture of, how often the patient is refluxing. There's buttons on the receiver, so when they feel heartburn or regurgitation, they push buttons for that. We can actually adjust the receiver for whatever their most significant symptoms are, so that we can see when they're actually pushing those buttons, do they correlate with actual reflux episodes. And then the capsule itself sheds off in about 7 to 10 days, and people may see it in their stool and just flush it down the toilet. So those are 2 tests. The third test is esophagram, which is a radiographic study. So patients go to radiology, they drink some contrast, and they take some pictures. And here at St. Jude, we actually record a little bit of video, so we get a good look on how well a patient swallows. It's essentially what I call my roadmap for surgery. It may show a hiatal hernia. And then the fourth study is generally esophageal manometry, which is another catheter-based study that's done in the GI lab. We pass a small catheter after anesthetizing the nose and the back of the mouth down through the esophagus into the stomach, and we have the patient do a series of swallows, which gives us a really detailed look at how well the esophagus swallows, because as a surgeon, it's important that we want to make sure that when patients are swallowing, that their esophagus is kind of contracting in a nice coordinated manner and peristalsing that food down. Because if it's not, it may alter what we could offer the patient surgically. Those are the 4 main studies that most reflux surgeons would evaluate a patient for potential anti-reflux surgery. There is a 5th study, which is a gastric emptying study, which generally looks for how well the stomach empties. Those we would generally get that in patients who had symptoms of nausea and vomiting, what we call early satiety, or meaning they get full quickly, which may suggest that there may be an underlying gastric motility disorder.
Wow, that capsule test, that sounds pretty useful and quite exciting as a tool for what you do.
Yeah, well, the other catheter, the other method of doing it, I think kind of the older way, was a catheter-based study where we put a catheter down through the nose, down into that distal esophagus, and we kind of put it behind the ear and tape it to the patient's face and say, go live a normal life. But unfortunately, patients weren't going out to eat. They're not going to the mall because they have a catheter coming out of their nose. So they were just kind of sitting at home. So it wasn't really reflective of their true lifestyle. So at least with the wireless technology now, and again, we can extend that out to 4 days of studying the reflux. It's a much more patient-friendly way of getting that objective data.
Yeah, I believe it. So one of my best friends takes Prevacid, which is a proton pump inhibitor, every day, and it works really well for them. But if medication isn't working, what other options are available to patients? Is surgery ever necessary?
Yes. So, and I will tell you that the medications work, right? But the studies that have looked at this, the same volume or quantity of stuff is still refluxing, right? So it's still coming up. The patients just feel better because obviously it's less acidic. And so I think, as medications, I usually think of reflux disease on a continuum. So is that valve, right, is starting to fail, right? I think medications still have a role, right? Because obviously there's risks with surgery. But as that valve continues to deteriorate and not function as properly, that's where patients develop breakthrough symptoms, right? Or symptoms that aren't responsive to the medical therapy anymore. And so generally, outside of medical therapy, there are anti-reflux surgery options, and that's where there's a few different options nowadays. The traditional surgery is a traditional fundoplication. The surgery itself, the term fundoplication comes from the part of the stomach called the fundus, which we wrap around that weakened valve surgically. And then we plicate it or suture it to itself. So hence the term fundoplication. That surgery's been around since the 1950s. But we've been doing it minimally invasive since the early 1990s. So that generally involves 5 to 6 small incisions in the patient's upper abdomen. We generally go in there, would repair any type of hiatal hernia that was there. And just to clarify for the audience, a hiatal hernia is where that valve, instead of remaining in the abdominal cavity, starts to bulge up and down into the chest, and has about a 68 to 80% chance of being associated with reflux disease. So generally, we would repair that at the time of surgery, and then again, take that top part of the stomach and wrap it around the various degrees around that weakened valve. That procedure takes about an hour and a half to 2 hours. Generally, patients spend 1 night in the hospital, generally are back at work or school within 2 weeks. Very, very effective in controlling reflux. The studies that have looked at this show 90% effective in controlling reflux and getting patients off their medications and improving quality of life. But it's kind of gotten a bad reputation over the years because it's almost too good of an operation. When we do a full fundoplication or Nissen, patients generally have the inability to belch or vomit, which may not be a big deal to a lot of patients, but we all swallow air when we talk and when we eat. And if you can't belch, then the gas or bloating can be problematic. And that's usually temporary, lasts about 3 to 4 months, but a small percentage will still experience gas or bloating in about 1 year from surgery. So now, if I was seeing a patient about 15 years ago, that would be all that I could really offer the patient. But there are some newer alternatives now that have as favorable or equivalent success with much less side effect profiles. So two of those newer technologies are the Lynx device, which is a bracelet of magnetic beads that we place around the distal esophagus. So that's really not like, we're not wrapping the stomach around that weakened valve. It's a bracelet of magnets that's used to augment the natural function of that valve. So you can imagine if that valve wants to expand, these magnets engage to really help keep that close. That's been shown to be as effective as the traditional surgery in controlling reflux, but the side effect profile is much more favorable. The vast majority of patients can belch or vomit, and therefore the gas or bloating associated with the traditional surgery is greatly reduced. We also have an endoscopic version or fundoplication, so an incisionless option for patients that have small to no hiatal hernias, where we're basically doing a stomach graft from the inside, a partial stomach graft from the inside. This can be done in less than an hour, and generally can be done as an outpatient procedure. And again, the data show it's equivalent early on in terms of its effectiveness against reflux, but in a much less favorable side effect profile when compared to the traditional fundoplication. So it's kind of a long-winded answer to the different options that are available, but there's generally three broad kind of treatment categories that we have now that we can offer patients who are either not content taking their medical therapy or are having breakthrough symptoms despite medical therapy.
Wow. Well, we have a question from one of our viewers, and they were wondering about the studies that you mentioned earlier. Are they appropriate for patients that have gone through gastric bypass or are going to go through gastric bypass as well?
Yeah, I think many bariatric surgeons will often obtain very similar studies to evaluate patients for bariatric surgery. So I think most patients who are undergoing consideration for bariatric surgery will undergo an upper endoscopy, even more so if they have a history of reflux disease. As you may be aware, there are a couple of different options for bariatric surgery, but sleeve gastrectomy and the gastric bypass are the two main options. We do know that a sleeve gastrectomy can potentially worsen underlying reflux disease. So in patients who have documented reflux, preoperatively, they would best be served by a gastric bypass where there's a much less reduced incidence of reflux following bypass surgery. But generally, they would probably get some sort of esophagram or upper GI study as well as an esophagram. And again, depending on if they have reflux symptoms, they may or may not do a pH study.
That's very interesting. So there's a bit of overlap there. Okay. Well, for folks that may be experiencing some of these symptoms of GERD, but they don't necessarily have a hernia, they think they have a pretty healthy diet. Is it possible that there are medications they're taking for other illnesses that could be causing these symptoms?
Yeah, there are some medications. I think the thiazide diuretics are a kind of classic one. And there's some other ones that I can't think of off the top of my head that, due to their side effects, again, or when they're metabolized, they have breakdown products that can kind of relax that valve. But again, but that's not a common thing that I see, that patients are, the more common thing is patients are becoming more fearful of taking the medications that are designed to treat reflux over a long term because of potential side effects.
And what are some of those side effects that give them pause?
Yeah, so the H2 blockers or the histamine 2 receptor blockers are the drugs that originally came out for reflux disease. And these were like the Pepcids, the Zantacs, the Tagamints, the Axids. And obviously, Zantac been taken off the shelf for potential cancer-causing agents that were found in it, but Pepcid's still generally safe. But they weren't as effective as the stronger drugs in terms of the proton pump inhibitors. So that's your, the Nexiums, the Prevacid, the Protonics, and whatnot. So these drugs are generally 15 to 20 times stronger than the H2 blockers. So a lot of the times these are drugs that are first prescribed. But starting about 11 years ago, the FDA started coming out with some warnings with potential long-term use of these medications. So patients that have been on these drugs for 15 or 20 years. And at that time, it was potential for low magnesium levels, an increased risk of we call Clostridium difficile or C. diff diarrhea, as well as potential risk of osteoporosis or osteopenia, so more worrisome for women. And it's almost like every year since those FDA warnings came out, there's been another body system that's been affected. So there's been increases in community-acquired pneumonia, and potential for kidney damage or acute kidney injury. There's been links to cardiovascular risk factors for heart attacks, increased risk for pancreatic cancer, and even dementia has been implicated. So the data is kind of mixed on some of these. I think a lot of them, we do agree that potentially can affect magnesium levels. The bone loss, the data is mixed. We definitely agree that there's a potential for diarrhea or the C. diff diarrhea. But again, there's conflicting data for a lot of these risk factors. But patients see these headlines, and it raises concern. So,
yeah, I mean, those are some pretty scary things. I can see why they'd be a little nervous about continuing to take a medication for a long time if those risks are there. And you mentioned cancer, and so I was wondering, are there risk factors that pile on if GERD is left untreated? Can it lead to other health conditions like cancer or something more serious?
Yeah, so over time, GERD, if left untreated, can generally cause complications of reflux disease. And the general ones we worry about are esophagitis, and this is where the acid starts eating away at the lining of the esophagus. It almost looks like an abrasion if you were to fall down and scrape your knee. You see these abrasions on the inside of the esophagus. And if left over time, that initially can be treated with medical therapy and usually can respond, but over time it may become unresponsive and progress to more forms of scarring, what we call stricturing. So there's a narrowing in the esophagus. We know that over time, reflux can lead to loss of some motility within the esophageal body, meaning the peristalsis or the ability to swallow would be impaired and cause dysphagia or trouble swallowing. But the most feared complication is Barrett's esophagus, and that's what we call intestinal metaplasia. And I usually just tell patients it's where the lining of the esophagus changes to look more like the lining of the stomach or the intestines. So that's somewhat simplified, but as you can imagine, acid's used to going downstream, and so the intestines are used to handling it. So it's a protective mechanism within the esophagus, but unfortunately, it's a precancerous lesion. We will see that in about 15% of patients with reflux disease, but it greatly increases your chance of developing esophageal cancer. And so it's a progression over many times, that over patients who have 10, 15, 20 years of reflux disease, they can develop Barrett's esophagus, which can progress through various forms of dysplasia or low-grade to high-grade dysplasia, and eventually to esophageal adenocarcinoma, which is not a very popular cancer, meaning it's not very popular within social media, but there's been a tremendous growth. And I'll tell you about over 730% growth in the rate of esophageal cancer over the last 4 decades, just due to kind of poor surveillance and screening modalities to pick this cancer up early.
Wow. And I would imagine that if you happen to be a smoker, your risk would be much, much higher, right?
Well, yeah. So like many cancers, smoking and tobacco as well as alcohol kind of contribute to the potential increased risk. There's another form of esophageal cancer called squamous cell carcinoma, which used to be more prevalent many decades ago, but as people have kind of quit smoking. But that squamous cell carcinoma definitely has links with tobacco and alcohol use. Now, there are some associations with esophageal adenocarcinoma, some increased risk as an increased risk factor, but the data supporting it's not as strong as with squamous cell. So with the adenocarcinoma, which is the cancer we're talking about here, the number one risk factor is Barrett's esophagus due to prolonged reflux.
Oh, wow. Okay. So this has all been really fascinating for me. And I'm wondering if you had to narrow it down, what would you say is the biggest risk factor for GERD?
So the biggest risk factor, you mean contributing to GERD? Why that valve weakens, we really don't know over time. I would say the most common thing that I see are patients developing hiatal hernias. Now, hiatal hernias only affect about 15% of the population, but I think reflux disease is it's a serious disease, and a lot of people just take it as, oh, it's maybe I just have a little cough or I have a hangnail or something. It's not too significant, but it really is a serious disease. And if you look at statistically, about 1 in 5 Americans suffer from reflux, and this results in over 20 plus million patients on medical therapy for reflux disease, but yet only a small percentage come to the attention of a surgeon. All right. So, the risk factors I think that are probably most concerning for severe disease would be a family history of Barrett's esophagus or a family history of esophageal cancer. We know that there are certain patients who are at risk for developing Barrett's. So if you're, so again, to have Barrett's, you have to have reflux disease for at least 5 to 10 years as a minimum. And then if you're a male, if you're a Caucasian, if you're over the age of 50, again, if you have you've used tobacco in the past, and then if your symptoms are worse at night as opposed to when you're lying down as opposed to standing up. But then the family history again of Barrett's esophagus or esophageal cancers, those are kind of the risk factors that are more concerning and should be prompt. And if a patient has those, they should definitely see their providers to get an upper endoscopy.
Wow. Well, I'm definitely getting the message that self-diagnosing and self-treating with those over-the-counter drugs is probably not the best idea. We have one more question from our viewers. Are there any new therapies for reflux disease that are currently being studied that maybe you think are worthwhile and worth talking about?
Yeah, so therapies overall. So in terms of diet and lifestyle modification, if you look at the treatment kind of modalities, there's not too much really going on in there. But studies have shown that the most effective diet is a low fat diet, and then losing weight. So we know that if you gain weight, that you can increase your reflux. So in terms of the non-medical therapies, there's really not too much going on there, but recent studies have shown that losing weight is an important contributor of all those things. So obviously, pharmaceutical companies are looking at other ways to try to do this. As a surgeon, I'm not really up to date on what the current guidelines are. There are some other classes of proton pump inhibitors that are probably being worked on with potential less side effects. But from a surgical standpoint, I briefly mentioned the 3 main modalities that we have available to us. Other therapies have come and gone. There was a recent device that was looking at placing electrodes. It was called the endostim, placing electrodes into that sphincter muscle or that weakened valve, and having a little pacemaker. So almost like a cardiac pacemaker, but a pacemaker for this lower esophageal sphincter. But unfortunately, the early trials looking at this didn't really pan out, and the device has been withdrawn from the market. The endoscopic option that I mentioned, the TIF, there has been several endoscopic modalities that came out in the mid-2000s where there was a lot of excitement about incisionless surgery or scarless surgery. And unfortunately, a lot of them have come and gone either due to complications or they weren't very effective in treating reflux disease. And the TIF device or the endoscopic fundoplication is the one that's come out of there. So, but outside of the endostim, there's nothing really exciting kind of coming down the pike in terms of surgical treatments. So, but again, we now have 2 additional modalities that we didn't have even 10, 15 years ago.
Mm-hmm. Yeah, that's still great news. So we're just about out of time. Is there anything else you'd like to share with us today, other than not to overdo it on Thanksgiving dinner?
No, I just think if you're, I think because of the bad reputation from the fundification that's kind of come, for the potential side effects, a lot of patients are fearful of surgery. But if you have any concerns about your reflux disease, and again, a lot of my patients, never knew, didn't know that reflux could cause cancer, and some of them didn't know there were surgical options to treat reflux. The whole point of operating on reflux disease is really to improve your quality of life and to ideally get patients off their medical therapy. And so, have the discussion with your primary care provider, have the discussion with your gastroenterologist, because again, as more time comes out, there are some potential side effects associated with long-term use. So, and consider that referral for potential surgical evaluation. And if you're having any alarming symptoms like weight loss, dysphagia, especially with a family history of Barrett's esophageal cancer, definitely talk to your providers about getting that endoscopy to screen for esophageal cancer potentially.
Great. Well, thank you very much, Dr. B, for joining us today, and to everyone for listening and sending in your questions. If you're looking for medical advice, please visit us at providence.org, and make sure to follow Providence on social media at Providence on Twitter and under Providence Health System on Instagram, Facebook, and LinkedIn. Thanks again for joining us. We'll see you next time.
Thank you, everyone. Thanks, Brendan.
It was a pleasure.